As a social demographer, I use data for my work. I use data to create the empirical evidence to support my hypothesis or to disprove my hypothesis. When the Zika epidemic happened in 2015, there was no data available that could answer the kinds of questions, the kinds of research questions that were emerging at the time and that I was interested in. So I applied for a grant and I received the grant to then conduct a survey and to be able to answer the research questions that were appropriate at the time. So the idea there was Zika is a disease that is transmitted mainly by the Aedes aegypti mosquito. During the Zika epidemic in Brazil that started in 2015, it was discovered that pregnant women who were infected with the Zika virus had a higher likelihood of transmitting Zika to their babies while pregnant, and those babies had a higher likelihood of developing congenital Zika syndrome, which microcephaly, which is brain malformation, is one kind of congenital Zika syndrome. This, although Zika had existed before, this association between Zika and microcephaly was discovered in Brazil in 2015, and the place where this was first discovered was Recife, in Pernambuco. And that's where we based the project. We wanted to understand what were the consequences of that Zika, of that illness, to women's fertility intentions, contraceptive behaviors, sexual behaviors. What were women changing because of this huge shock that they were going through, that was centered in their reproductive health, right? So not only we were looking at the women who had babies with microcephaly, we were actually looking at all women and trying to understand if they were changing their intentions. Say, I wanted to have a baby now I decided to change or postpone or really forgo because of this epidemic. So that was one of the main research questions that we had. And then not only that, going one step ahead, looking at whether there were differences in the fertility intentions, also by women's positionalities, by women's social class, by women's race and ethnicity. What were the barriers? What were the patterns that we could, find or detect in terms of how this huge shock that was going on affected their fertility intentions, but also their contraceptive behavior? Were women deciding to contracept more? Were they able also to, that's another question, to meet their intentions, right? And to do all of that, we needed specific kind of data. We needed data that followed women over time to really see what's going on. So while we had data on births, excellent data from the Brazilian Census Bureau and also from other governmental agencies in Brazil, what we didn't have was this nuanced take to really understand what was going on in women's minds as they navigated that epidemic, right? So we set up a project. We were extremely lucky to have gotten funds to conduct this research. And it turns out that the project is called Demographic Consequences of the Zika and then COVID. I'll talk about COVID in a minute. Crisis. And what we do is we follow women over time, and we've been following women in the state of Pernambuco for 4 years now. We have 3 waves of data already, and we are on the field as we speak in 2025, going for our 4th wave. when we were ready to go to the field for the first time to collect our baseline data, it was more than a year of preparation, of planning to set up, a team, a fieldwork team, all in Brazil and etc. What happened? COVID started. So we had a data set infrastructure ready to knock on women's doors to ask all those questions. And we had to stop everything because we could not obviously collect data in the middle of COVID, data that was face-to-face that required contact. So we had to change everything to non-contact modes of survey research. That's when we started phone interviews. One thing that's very important is that all of our data collection, quantitative data collection, is population representative, which means that those women are selected at random, and we can infer, our findings can infer about the population as a whole. This is extremely important. It's hard work, but it's extremely important to be able to have the best scientific results, empirical results that are based on probability theories and et cetera, et cetera. That's the kind of data that we collect. So we started to collect the baseline for the DZC project, the baseline data in 2020 in Pernambuco. We have women in 94 different municipalities, which gives us great variation in terms of their exposure of lots of things, including the disease in itself, but which also gives us the ability to understand how they were close or far from people infected. And what that gives us is the chance to look at not only their distance to high infected areas or areas with high death rates in the case of COVID, but also we ask them about their own feelings and about the diseases, if they had seen people around with the diseases, but also we ask them how many people they knew who had the diseases. So all of those questions combined give us the ability to look at the macro level, how close they were, how exposed they were to the diseases, but also at the micro level, the individual level, how close they were. For diseases that are new, like Zika and the consequences of Zika at the time, and also COVID a couple of years later, that's very important because that's how people learn about those things, right? Through their networks. So another important component of DZC, which made DZC was first DZ, and then it became DZC because COVID hit. And so the big research question of the second phase of the project is to look at the consequences of back-to-back crises on women's reproductive health and reproductive behaviors and intentions. So what that means is, one of the questions that we are interested in answering is, the women who were exposed to the first disease at high levels handled the second one differently than women who were not as exposed. And so this is very interesting because it gets to our innate question of what does experience ease things for us, ease resilience. Does that lead to resilience, or does that lead to different patterns or similar patterns? So you can think of ways that this can be applied, not only in terms of how people navigate infectious disease crisis, but also how they navigate shocks overall, right? And that's what we are trying to answer in that second phase of DZC. So for the first phase, we were funded, and for the second phase, we are funded again. And so we are continuing to follow these women. We are adding new women to the panel. And this is the first panel with women of reproductive age in Brazil ever done. And so this has the potential to answer many other questions, because we also ask about the babies, if women were pregnant before, during the panel, and this will take 6 years to complete. So we keep following them, and so we can answer questions related to the well-being of the baby's birth weight, gestational period, all those kinds of questions, as well as the back-to-back nature of those diseases, like I said.